Dear friends and colleagues, my name is Marco Metra. I'm currently president of the Heart Failure Association of the European Society of Cardiology. It is my pleasure and honor to present the best of the HFA Congress, which has just taken place in Belgrade in May this year. I will focus on mostly on presentations regarding chronic heart failure and something also on devices. So let's start. These are my disclosures. These are not original data presented at HFA in Belgrade, but one of the major advantages of SGLT2 inhibitors for the treatment of heart failure is their ability to stabilize kidney function throughout the years. And here you have the data from DAPA-HF and the EMPEROR trials showing that with dapagliflozin and empagliflozin, there is a stabilization of renal function during treatment. So what it is the clinical significance of worsening kidney function? We already had an analysis from Paragon HF, a trial with sacubitril valsartan in patients with HFpEF, showing that the worsening of kidney function not only follows an hospitalization for heart failure on the right, but also precedes, occurs in the year before, an hospitalization for heart failure, likely because the patients become resistant to diuretic therapy. A similar analysis has been presented in Belgrade in this year, and these are from two different or three different cohorts, one from Eplerenon trials, Ephesus and Emphasis, and the other one from a cohort from Barcelona. And in all cases, kidney function was monitored, measured in the year before and then after the hospitalization for heart failure. And as you can see here, in the year before the hospitalization for heart failure, there is a decrease in kidney function, and this actually occurred to a larger extent in the patients with a worsening of New York Functional Class. And this deterioration in kidney function also followed in the year after. You see here, for example, in the year before, there is a 2.13 decrease in GFR, which becomes 5.77 in the patients with New York Heart Class worsening, and then a further deterioration of kidney function. So when we see the patients and we see our patients with a deterioration of GFR, think that this is also something that predicts a possible hospitalization for heart failure. And remaining on the topics of rehospitalizations for heart failure, we know that in patients with preserved ejection fraction, not only the SGLT2 inhibitors, but also finerenone have been shown as effective in reducing heart failure hospitalizations. These are data from Fine Arts regarding recurrent hospitalizations and showing that the drug was effective in reducing early heart failure events, and also including the patients who were randomized within 7 days from hospitalization. You see that all heart failure readmissions and heart failure readmissions or urgent heart failure visit were significantly reduced by finerenone versus placebo. Let's move to this one. This sorry, I go back. Now, what else regarding diuretic treatment in the patients with chronic heart failure? This is a trial of withdrawal of diuretic treatment in patients who were clinically stable on optimized medical treatment. And in this trial, the authors were able to show that it's in a selected relatively small number of patients, but in these patients, the withdrawal of diuretic treatment was not associated with any worsening of symptoms or any worsening of heart failure events. So in patients who are clinically stable, New York Heart Class 1 and 2, euvolemic, on optimal medical treatment, diuretic withdrawal can be tried. This is are other interesting data regarding patients with chronic heart failure, and actually the prognostic effect of practicing active sports. And this trial show this analysis of epidemiological data show that patients practicing active sports had a better outcome, even for cardiac death and all-cause death, compared to patients with heart failure that did not practice active sports. What remains? Patients with chronic heart failure have a relatively high residual risk of heart failure events. And this is why new drugs such as vericiguat are currently undergoing assessment in a multi-center randomized controlled trial such as Victor, which will be presented at the next ESC Congress. But however, vericiguat has been already shown as effective in Victoria in patients at high risk of events. You see here the comparison with the SGLT2 inhibitors trials. And here we have the data of Victoria, so that despite the smaller relative risk reduction, the absolute number of events was lower with vericiguat. What was presented at Belgrade meeting was the Velocity trial, which is a trial of quick up titration of vericiguat dosing in patients with chronic heart failure. And you see that the patients with chronic heart failure and reduced ejection fraction tolerated a quick titration of vericiguat, starting with a dose of 5 milligram daily. Coming back to finerenone, and that's what I was thinking initially, we had the presentation of data regarding the withdrawal of finerenone in the Fine Arts trial. And these data are very interesting because in the patients enrolled in the Fine Art trial, there was a double-blind withdrawal, and then the recording of events in the month following the withdrawal. And what you see is that there is immediately an almost threefold increase in major heart failure events, heart failure hospitalizations or cardiovascular death in the patients who were previously on finerenone, so that they had a lower risk compared with placebo, in the patients who were previously on finerenone. So the treatment must be continued, and the withdrawal of treatment has an almost immediate effect on events. Iron therapy was recently studied in the FAIR-HF trial, a trial whose data were presented last year and that are summarized here, were actually not this year at the ACC Congress. And patients on chronic heart failure were randomized with iron deficiency were randomized to ferric carboxymaltose versus placebo, and there was a reduction in the events, primary outcome of the trials, which, however, did not reach statistical significance. However, when the data were analyzed in meta-analysis published in Nature Medicine, you see that the administration of IV ferric carboxymaltose was effective, reducing cardiovascular deaths or recurrent heart failure hospitalization, as well as recurrent heart failure hospitalizations alone compared with placebo. So there is an improvement in outcome. There are some other sub-analyses that were presented at the Belgrade meeting that are potentially important. A first analysis regards the role of serum transferrin levels. You see that in the previous meta-analysis of iron therapy, serum low T-set, low serum transferrin absolute saturation was a predictor of the beneficial effects of ferric carboxymaltose versus placebo. Actually, iron replacement was effective only in the patients with low serum transferrin saturation levels and not in the patients with normal levels. However, these data were not replied in FAIR-HF, and as you can see already here from the data on the main study, there was no interaction between serum transferrin saturation and the efficacy of iron therapy versus placebo. Here are the data that were presented by Professor Stefan Anker at the Belgrade meeting. You see that the hazard ratio for heart failure hospitalization or cardiovascular death was actually the same in the patients with low or high T-set. And here you see the analysis for recurrent heart failure hospitalizations. And as expected, the patients with a low T-set had more heart failure hospitalizations, and therefore the effect was somehow numerically larger, but again, no interaction. The same when the 6-minute walking test distance is evaluated, T-set was not a predictor of the response. Another analysis, which was statistically robust but needs probably further validation, is the one by sex. Actually, a major difference in the effects of iron therapy was found in, according to the sex, was found in male but not in females. Females are here below. You see that there is no difference in the events according to iron therapy. Also when recurrent heart failure hospitalizations are considered, whereas the difference is extremely large in the males. These data need further validation, but again, were very statistically robust in this analysis of FAIR-HF. Now, do we still have to base our treatment on IV iron? Well, this may not necessarily be the case. We have had previous preliminary data in single center regarding oral sucrosomial iron. that improved the exercise capacity and increased the serum ferritin level to the left in the patients with chronic heart failure and iron deficiency. And we have had the presentation in Belgrade of the preferred HF trial, where oral iron therapy with sucrosa-homial iron has been tested in patients with heart failure and preserved ejection fraction and iron deficiency. Actually, the trial was neutral with respect to the changes in the 6-minute walking test distance, and also there was, however, an increase in iron plasma levels. You see, very important that with respect of events, there was a tendency that, however, did not reach statistical significance in favor of oral sucrosa-homial iron therapy. Therefore, there are promising signals that, however, need further confirmation. What can come from the future? Paradoxically, we may wait for results with digoxin and digitoxin therapy. There are currently two trials, the one in Germany, Austria, and Serbia. DigitHF is with digitoxin versus placebo, and there is another one in Netherlands with digoxin versus placebo. And in Belgrade, we had the presentation of the baseline characteristics of the patients, which were similar and comparable to those of the most recent trials with SGLT2 inhibitors or sacubitril/valsartan in the patients with heart failure. And in the ESC Congress, we will have the presentation of the main results of this DigitHF trial. A large interest has regarded the data on implementation of medical treatment in the patients with heart failure. And we have had data actually from national heart failure registries, and this is an analysis from Sweden. And you have in pink the years after the 2021 heart failure guidelines. And what you can see regarding the implementation of medical treatment is that there has been in these last years an increase in the number of patients receiving mineralocorticoid antagonists, as well as ARNI and SGLT2 inhibitors, dapagliflozin and empagliflozin, have actually had a large increase in their use. Interestingly enough, mirroring these changes in the implementation of evidence-based medical treatment, there has been a decrease in the number of heart failure hospitalizations, whereas mortality has remained the same in these last years. This is again from Sweden, and you see adherence and persistence of treatment. So the patients are monitored regarding how many patients receive quadruple therapy 1 year after the diagnosis of heart failure. And you see that the numbers are good. We may say 68% of the patients persist on quadruple therapy. And you see also that the persistence on treatment with SGLT2 inhibitors is very high, 86% of the patients, quite comparable to that one with the other pillars of medical treatment of heart failure. And here you see also how the treatment with the SGLT2 inhibitors was associated with a decreased risk of heart failure hospitalizations and cardiovascular death. Of course, the confidence intervals are larger for 1 year persistence because of the smaller number of patients on treatment at that time, but the data are consistent, showing that implementation of quadruple therapy can really improve the outcome of our patients by reducing major events by an average of 12-20%. This is an analysis from Netherlands. These are data already published, but we have had an interesting update presented in Belgrade, and this regards the implementation of the quadruple therapy in the patients with a new diagnosis of heart failure. And you see that almost all is done in the first 30 days after the new diagnosis. There is some further implementation in the following month, but then the patient has reached a plateau. So this is important because it seems that we do nothing more when we see our patients on an ambulatory basis and when they are chronic. You see that the predictors, and these are the data that are more important to show. These data regard the changes in ejection fraction with quadruple therapy in 752 patients monitored in Netherlands. And what you can see is that after 1 year of quadruple therapy, 60% of the patients end up with an ejection fraction above 40%. So virtually no indication to defibrillator therapy. And this is very important to point out. This is an analysis that we have done in Italy. It was presented by Dr. Riccardo Inciardi at HFA Belgrade. You see the implementation in more than 3,000 patients from 32 Italian centers, the implementation of the different medical therapies for heart failure. After a first visit, you see that the larger increment occurred with respect of SGLT2 inhibitors, either in patients with FREF and FMREF and FPEF. And you see that quadruple therapy was used again, the larger increase with quadruple therapy was in the patients with FREF, but also in the patients with mildly reduced ejection fraction. And of course, FPEF, there is no tight indication except for SGLT2 inhibitors. It's also important to point out that however, clinical inertia is still very important. These blue areas are the patients not treated despite no contraindications, and you see that there is a major undertreatment with ACE inhibitors and ARBs, but also 23% of the patients do not receive ARNI, and they could. 18% do not receive MRAs, and still 1/4 of the patients at least 1 year ago did not receive SGLT2 inhibitors despite no contraindications. Then there is also underdosing of quadruple therapy. To end, other major advances have been shown regarding therapy of amyloid cardiomyopathy. Actually, this analysis of HELIOS-B with Risiran versus placebo showed an improvement in reduction in all-cause mortality. This analysis with aficamten in patients with hypertrophic cardiomyopathy demonstrated a clinical benefit independent of symptoms burden. And then we have continuous advances in monitoring systems, above all with external units that monitor lung thorax impedance as a sign of congestion. And we have had also this analysis of a new device. This is my last slides, that monitors inferior vena cava collapsibility and diameter as a sign of right ventricular filling pressure, and it has been successfully implemented in patients with chronic heart failure. I thank you for your attention.